Management of severe anemia and heart failure in patients with severe acute malnutrition. Severe malnutrition causes physiological and metabolic changes in multiple systems of the body. Cardiac contractility, cardiac output, and stroke volume are impaired in these individuals. Electrolyte derangements such as hypokalemia compromise cardiac function further. In addition to this, there is a reduced number and activity of sodium-potassium pumps in cells, which leads to intracellular sodium retention and worsens edema. During treatment of malnutrition, the sodium pump is stimulated and large amounts of sodium leave the cells and potassium enters the cells, causing an increase in intravascular volume and hemodilution and hypokalemia. If increased activity of the sodium-potassium pump happens rapidly, sodium may be exported into the intravascular space faster than the kidneys are able to excrete it out of the body. This situation is exacerbated by giving intravenous fluids or blood transfusion and may result in acute heart failure and sudden death. Close monitoring of weight gain, heart size, liver size, and respiratory rate should be carried out for all patients during nutritional rehabilitation. Intravenous fluids should only be given to patients in shock to reduce chances of overhydration and heart failure from excessive intravenous fluid administration. Severe anemia in patients with severe acute malnutrition may be associated with bacterial sepsis, hookworm infestation, repeated bouts of malaria, HIV infection, or micronutrient deficiency. Investigations should be done to investigate for all the causes of severe anemia requiring transfusion. Patients with severe acute malnutrition should receive blood transfusion if they have severe anemia, defined as a hemoglobin concentration of less than 4 grams per deciliter, or if they present with severe palmar pallor. Blood transfusion may also be given if hemoglobin concentration is 4 to 6 grams per deciliter and the patient shows signs of respiratory distress. Patients with severe acute malnutrition should receive a reduced volume of blood during transfusion compared to those without malnutrition. And liver size, heart rate, and respiratory rate should be closely monitored during transfusion to detect fluid overload early. Transfusion should also be given more slowly. Here is an algorithm that describes the management of a child with severe acute malnutrition who has severe anemia. Check for the presence of signs of congestive heart failure. That is, check for fast pulse, respiratory distress, engorgement of superficial veins, cold peripheries, cyanosis, gallop rhythm, and a tender enlarged liver. If these signs are present, give 10 milliliters per kilogram of packed red cells or whole blood per kilogram of body weight slowly over 3 hours. Give furosemide 1 milligram per kilogram. If these signs are not present, give 5 to 7 milligrams per kilogram body weight of packed cells slowly over 3 hours. Give furosemide 1 milligram per kilogram body weight at the beginning of the transfusion. Remember to stop all oral intake and intravenous fluids during the transfusion. Anemia associated with heart failure later in the course of treatment may be dilutional anemia caused by expanding plasma volume. This anemia should not be treated with blood transfusion even if the hemoglobin level falls below 4 grams per deciliter. The child should be treated for heart failure only. This usually occurs between 48 hours to 14 days after the start of treatment. Iron supplements should not be given in the initial phase of treatment. Iron may be toxic at this stage and may impair resistance to infection. In summary, patients with severe malnutrition are at increased risk of fluid overload and cardiac failure. Unnecessary blood transfusion and intravenous fluids may increase the risk of mortality in severely malnourished patients. Intravenous fluids should only be administered to patients in shock. Blood transfusion should be given if hemoglobin concentration falls below 4 grams per deciliter or is in the range of 4 to 6 grams per deciliter in the presence of respiratory distress.